Hello, I'm Brett Crist. I'm a professor at the University of Missouri in Columbia, Missouri, and I'm an orthopedic trauma surgeon. And I've been here for about 18 years. And the title of my case is Maneuverability Makes It Work. And so my patient was a 69-year-old female who fell onto her right side while kind of leaning up against an automated door. She fell 3 weeks prior, and when she presented to clinic, she was having pain with weight bearing in her right groin and occasionally using a assistive device prior to her fall. She does have some pretty significant medical comorbidities, including non-insulin dependent diabetes. She is obese. She has multiple sclerosis and hypertension. And then, as you can see on her AP image, she has had a previous lumbosacral fusion, but has also had two total knees. Those have been working fine. On physical exam, she was tender to palpation over her pubic ramus and had limited internal external rotation of her hip, secondary to pain. And at presentation, she did not have any pain posteriorly. So these are different views that we have. They didn't really have a great inlet view initially, and so we had to repeat that. But these are her AP pelvis and outlet views. And you can see there's really not significant displacement of her pubic and ischial rami fractures. And this is her inlet view showing no significant or really any rotational deformity. And it's really not evident that there's any posterior ring injury on plain imaging. And so she ended up getting a CT scan in the ER, which shows her pedicle screws in her sacrum to be intact, no obvious posterior ring injury. You can see her rami fractures are not very complicated. And interestingly enough, she must have had some either injury beforehand, or she already started trying to generate callus at 3 weeks in her ischial ramus fracture, which I would say would be pretty unique for somebody in her age range. These are coronal reconstructions, as you can see here, and it just verifies that there's no significant deformity associated with her rami fractures. Here are sagittal plane reconstructions. She didn't really have any sacral dysmorphism or any irregularity of her sacral corridors except for her indwelling hardware. And this is just inlet view 3D reconstruction showing that her overall alignment of her pelvis looked good at that standpoint. So the plan was non-operative management. She was weight bearing as tolerated, working with physical therapy, and planning to follow up in 1 month with referral to our bone health team for evaluation and management of osteoporosis. She eventually worked with physical therapy while she was in the hospital and was discharged to a skilled nursing facility. She came back a month later, so this is now about 7 weeks from injury, and she saw a colleague of mine and had no x-rays at that visit for some reason. She had been discharged from a skilled facility a week prior. She was still having 8 out of 10 groin pain, ambulating with a walker. She did have less groin pain than on her initial exam, and 4 out of 5 hip flexion, but it was painful and was going to transition to outpatient physical therapy and follow up 1 month later. She did end up getting evaluated for her bone health, and these are some pertinent labs. And she was scheduled to get a DEXA scan, but she did not do that. But she had some chronic elevation of inflammatory markers. Her vitamin D level was normal. Her thyroid level was normal. She did have an elevated parathyroid hormone level, and prealbumin was okay, indicating that her nutritional status was okay, despite it doesn't matter if you're obese or not, you can have abnormal protein levels. And for some reason, she did not follow through with her DEXA scan. This is her the 1 month later. So this is at the 11-week mark. And so you can see that she's trying to generate some callus on both rami fractures. There's no change posteriorly that I could tell on plain imaging. but there's no progressive deformity, rotational deformity, or sagittal plane deformity. So then she gets hospitalized for heart failure, which is obviously no good. And she works with the cardiac team and is doing some cardiac rehab. And she could presents at 5 months. She has significant limitation of activities of daily living due to her groin pain. She's walker and wheelchair dependent. She actually said her 90-year-old mother is more active than she was at the time, and that frustrated her. She started having posterior pain, but was still having more anterior pelvic pain than posterior pain. And this is what was limiting her daily function. And on exam, she did have pain with hip rotation. And she was tender palpation over her right sacrum at that visit. And you can see that she is trying to generate callus on her AP imaging. And so in talking with her about treatment options and with how far she's out from her original injury and how debilitating this injury has become, you know, she had delayed union of her rami fractures. She started having posterior pelvic pain, and her pain was still prolonged and limiting her daily function. And she actually had less function than she previously did. And so what are her specific risk factors for pelvic non-union? I would say her lumbosacral fusion is creating significant rigidity in her posterior pelvis. And so she will see more motion at the front of her pelvis because her posterior pelvic ring and lumbar spine is not really moving very much. And I've seen more geriatric or elderly patients get sacral insufficiency fractures related to lumbosacral fusions. At least that's I don't think that's only my opinion, but it just is so rigid back there. And then as their bone quality decreases, their risk of insufficiency or worsening fractures with falls, like more complex fractures, at least I've personally seen over the last kind of 5 to 10 years than previously. She also has had a previous gastric bypass, which has been shown to significantly increase the risk of osteoporosis. Basically, within 4 years of getting a gastric bypass, the incidence of distal radius fractures goes up significantly, and that's thought to be secondary to poor bone quality. And then she also has a family history of osteoporosis. So her problem list is her right pubic and ischial delayed union, right sacral pain. She's had her lumbosacral fusion. Obesity is supposed to be protective for osteoporosis, but it makes surgery harder, both imaging as well as access. And then her lumbosacral fusion limits the real estate into the first sacral corridor. And I thought she had a big enough second sacral corridor, but I really feel like the rigidity problem is in the first sacral segment. And so I felt like I needed to stabilize that sacral segment to make her pain improve, because if I just go with the level below it, she could potentially create a stress fracture between her lumbosacral fusion and whatever implant I use in the second sacral segment. So I thought it was important to be able to fix the first sacral segment. So these are intraoperative images. And this is, I thought, really demonstrated kind of the maneuverability or flexibility or the benefits of CurvaFix, because I did not think I could get a standard cannulated screw device across the first sacral segment. So this is the first attempt at getting the guide wire across to the opposite side. And I felt like I wanted to go into the opposite ilium. So transiliac transsacral fixation. And that was the inlet view. Here's the outlet view, and just different sequences of trying to get readjusting the wire and getting it around through the safe corridor. And I think that's a significant benefit of this technique, is even in poor bone quality, you can tell when you're getting to the periphery of the bone or the safety of the corridor. And so this is getting it across, and you can see here with I had the wire across further, but couldn't really get the reamer across the pathway because of the pedicle screws. And so attempt number 2, I decided to go actually try to go above it. And these are just more images showing maneuvering the guide rod above, and then below again. I felt like I got more posterior, so there would be more room And so there's the final positioning of the wire. And then just more imaging showing getting it to the opposite side in preparation for placing the CurvaFix device. And then the device going across. And I thought these were pretty neat images showing how it's making its way across and changing position or maneuvering its way across the pathway and getting to where it needs to go, getting past the lumbosacral fixation and getting finally seated and showing that it's down. And then finished by placing a retrograde ramus screw, which her corridor was too small for the currently available CurvaFix. And so just a 4.5 millimeter cortical screw. And so she was made weight bearing as tolerated, resumed her anticoagulation that she was started on for her heart issues. And then plan was to return to the bone health team and do physical therapy. And these are her post-operative images, including Judet views and the standard inlet and outlet views. I was concerned due to her bone quality about implants starting to back out at 3 weeks, but these are her 3-week images showing that there hasn't been any back out. And she was doing better pain-wise. She'd been doing actually significantly better from when she was in the hospital. And then she presented, it was actually a week ago, to the ER after a fall. And she had an episode where she passed out. She was evaluated, and her main complaint was her right shoulder, her left total knee, but no increased pelvic pain. And so I just actually saw her this week. And I thought on her images, again, clinically, her shoulder was the thing that was bothering her. She really had really minimal tenderness over her left SI joint, but these are her images. I thought she was increasing her callus formation on her rami fractures. And she feels like her main issue is getting her balance and these episodes of passing out kind of figured out. She didn't have any groin pain on range of motion, which was a significant improvement from prior to surgery. She was still using a walker. And I felt on exam that she really had a rotator cuff injury, which she had previous rotator cuff surgery. And she also had glenohumeral arthritis, and I didn't include those images. But the plan for her pelvis, so I'm going to have her see one of my shoulder partners, but her plan for her pelvis is to follow up in 3 months with new x-rays. But I thought from her pelvis, her pain had significantly improved and she was happy with it. So in summary, geriatric pelvic fractures aren't all non-operative management. There are definitely, we have a protocol if patients can't mobilize with therapy after three attempts that we consider acute fixation, but she had been doing okay prior to her continued difficulty healing and progressive pain and decreased function. Fixation does improve pain and function, and this has been demonstrated in the literature, especially outside of the US. And having a maneuverable implant made this surgery possible. I really thought getting fixation in the first sacral corridor was important to avoid an interprosthetic fracture, especially an insufficiency fracture down the road. Thank you.